Ever feel like you need to get your head around something really important, but you just don't have the hours to wade through all the details?
Yeah, happens all the time.
Well, today we're kind of handing you the cheat sheet for a critical area, especially if you're gearing up for the NCLEX-PN. We're talking mental health disorders. Think of
Mm-hmm.
this as your power-up, giving you the core nursing knowledge you need to confidently understand and apply these concepts in all sorts of situations.
That's right. We've thoroughly examined Chapter 62 of the Saunders Comprehensive Review for the NCLEX-PN Examination, the 7th edition. It's a dense chapter, for sure.
It really is.
But we're here to distill it down to the essential nursing insights.
Our goal today is, well, pretty straightforward. To extract all the really crucial nursing information from this chapter.
Yep.
We're talking about how to assess patients, what procedures are involved, the absolute must-knows for safety, what actions take priority, and even like getting a handle on those end-of-chapter review questions.
I'll cover it all.
We'll make it comprehensive, but hopefully in a way that actually sticks. And if any of the medical terms sound like a foreign language, don't worry, we'll translate.
Absolutely.
This chapter lays such an important groundwork for anyone in mental health nursing, so let's dive in.
Okay, to start, let's unpack something fundamental that touches all of us.
Anxiety.
Anxiety. Yeah, in its essence, it's a very normal, very human response to stress.
Yeah.
It's that feeling of unease, that sort of subjective sense of apprehension or even dread when we perceive a threat.
Okay.
What's interesting is that these threats aren't always, objectively real. Sometimes they stem from how we interpret situations or even threats to our own sense of self.
Ah, okay.
And it also often pops up when we feel our core beliefs are challenged or like when we're facing something new. I think of it as our internal alarm system kicking in.
Right, so it's not always a negative thing then. The book breaks it down into different types. What's the difference between them?
Exactly. Not always negative. There's normal anxiety, which is that short-term, almost energizing feeling that helps us cope with immediate situations. Healthy stress, basically.
Mm-hmm.
Then we have acute anxiety that's typically triggered by a specific, identifiable loss or a significant change that shakes our feeling of security.
Okay.
Chronic anxiety is different. It's more of a persistent state, almost like a baseline way someone responds to everyday life stressors. It's that ongoing worry that can be really, really draining.
Okay, so those are the broader categories, but the chapter also talks about levels of anxiety, right? From mild all the way to panic. How do those distinctions help us as nurses?
Oh, understanding the levels is crucial. It directly impacts how a person perceives and processes information and therefore how we need to interact with them.
Makes sense.
So mild anxiety is what we all experience, that everyday tension. It actually heightens our awareness, our perceptual field widens, and it can even motivate us. Like being mildly anxious before an exam, it can drive you to study.
That makes total sense. A little bit of nerve can keep you sharp. What happens when anxiety moves into the moderate level?
With moderate anxiety, the person's focus narrows. They zone in on immediate concerns. They might show selective inattentiveness, meaning they might miss things happening around them.
Okay.
However, and this is important, they can still learn and solve problems, just maybe not as efficiently as when they're mildly anxious.
So they can still engage and process information just with a more limited focus.
Yeah.
So, what about severe anxiety? How does that look?
Severe anxiety. Well, that's when that feeling that something bad is about to happen becomes very real, very intense. The perceptual field significantly narrows.
Okay.
The person might fixate on very small details or seemingly random things. Their behavior at this point is often aimed solely at relieving that intense anxiety, learning and problem solving. Extremely difficult. They'll likely need very clear, simple directions to focus.
That sounds really overwhelming for them. And then the most intense level is panic. What happens during a panic attack?
Panic is characterized by overwhelming terror and dread, often accompanied by a feeling of impending doom, like something truly catastrophic is about to occur.
Wow.
The person can appear completely disorganized, struggling to communicate or function effectively. Rational thought is lost, their perception becomes distorted, and they just can't concentrate. If someone stays in this state for too long, it can lead to exhaustion and, in very rare extreme cases, physical danger.
Those are some really clear distinctions. So when we're caring for someone experiencing anxiety, especially severe or panic levels, what are the immediate things we should be doing? The book talks about priority nursing actions.
The absolute priority, number one, is to create a calm and safe environment. This means reducing any external stimuli, things like loud noises, bright lights, a lot of people moving around. Cut down the chaos.
Right.
And crucially, stay with the client.
Mhm.
Leaving them alone when they're highly anxious can actually escalate their distress. Don't leave them.
That makes perfect sense, like being scared in the dark and someone just leaving you there.
Yeah,
Yeah.
exactly. The next vital step is to help the client identify what they're feeling and how intense those feelings are. Asking them directly helps them become more aware of the connection between their physical sensations, their emotions, and their behaviors.
Okay.
And that awareness can be the first step in reducing the anxiety. Encourage them to describe and talk about these feelings.
So giving them a voice and helping them make sense of what's happening internally?
Precisely. If they're having trouble understanding what's causing their anxiety,
Hmm.
help them explore potential triggers.
Mm.
While they're talking, really listen for any expressions of helplessness or hopelessness.
Red flag.
Big red flags. These can be indicators of a higher risk for self-harm. And of course, meticulous documentation of the entire event, what happened, any significant information shared, the actions you took, any follow-up needed, and how the client responded is absolutely essential.
Got it. Calm environment. Identify and discuss feelings, explore triggers, listen for red flags, and document thoroughly. What other general interventions does the chapter highlight for managing anxiety?
Well, beyond those immediate actions, it's important to first recognize when someone is anxious and then work to build trust with them. Protect them from any potential harm, both self-inflicted and maybe from external sources.
Okay.
Avoid criticizing any coping mechanisms they might be using, even if they don't seem ideal. These are strategies they're currently relying on. And never, ever push them into situations that you know will significantly increase their anxiety.
That sounds like it could be counterproductive and really erode trust.
Absolutely. Modifying their environment can also be very helpful. This could involve setting clear limits on certain behaviors, or if they're feeling overwhelmed by social interaction, perhaps limiting contact with others temporarily.
Makes sense.
Providing healthy outlets for their energy, like creative activities, art, music, can be beneficial. Activities that can distract them and limit the time they spend focusing on their anxiety-provoking thoughts can also be useful.
Good idea.
Encourage and teach relaxation techniques like deep breathing exercises or guided imagery. Finally, it's important to monitor their vital signs and administer any prescribed anti-anxiety medications as ordered. But remember, the immediate go-to for acute anxiety is always decrease stimulation, provide a calm, quiet space.
Okay, that gives us a really good overall understanding of anxiety. Now, the chapter moves on to specific anxiety disorders, starting with generalized anxiety disorder, or GAD. What are the key characteristics of GAD?
Right, GAD. Generalized anxiety disorder is marked by persistent and excessive worry about everyday things. Lots of different things. The anxiety is unrealistic, difficult to control, and it persists for a significant period.
And it's not tied to anything else.
Correct, not tied to any other specific psychiatric or medical condition. What's noteworthy is that people with GAD often experience physical symptoms alongside their constant worry.
So it's not just mental worry. There are physical manifestations, too. What kind of physical symptoms are common in GAD?
Common physical symptoms include feeling restless or on edge, being easily fatigued, having difficulty concentrating, irritability, muscle tension, and sleep disturbances, like trouble falling asleep or staying asleep.
Okay.
Interestingly, individuals with GAD may not always connect these physical sensations directly to their anxiety. They might focus more on the physical discomfort itself, maybe thinking it's a separate medical issue.
Okay, so for GAD, would our interventions be similar to the general anxiety measures we just discussed?
Exactly. The chapter pretty much directs us back to those general nursing interventions for managing anxiety. Provide calm, help identify feelings, relaxation techniques, the whole toolkit.
Got it. Following GAD, we move to panic disorder, which involves those really intense episodes we touched on earlier.
Right, those unexpected and sometimes expected panic attacks. What makes panic disorder a distinct diagnosis is the recurrence of these unexpected attacks.
Unexpected being key.
Often, yes. While sometimes there might be a trigger, frequently these attacks seem to come completely out of the blue. They are characterized by a sudden surge of intense fear or discomfort that peaks within minutes.
Okay.
And during that time, several physical and/or cognitive symptoms occur. These attacks are severe, really frightening for the individual experiencing them.
What kind of symptoms might someone experience during a panic attack, as described in the chapter?
The chapter lists quite a few. Palpitations, a pounding heart, sweating, trembling or shaking, sensations of shortness of breath or smothering, feelings of choking.
scary.
Chest pain or discomfort, nausea, feeling dizzy or faint, feelings of unreality, that's derealization, or feeling detached from oneself, which is depersonalization. Also a fear of losing control or going crazy, and even a fear of dying. Numbness or tingling, chills or hot flashes are common too.
Those sound incredibly distressing. And for panic attacks, do we also rely on those general anxiety interventions we talked about?
Yes. The immediate interventions during a panic attack are largely the same as for severe anxiety. Stay with the person. Provide that calm environment. Speak in a low, calm, reassuring voice, and help them focus on their breathing. Slow, deep breaths.
Okay.
After the acute attack passes, we then explore potential triggers and work on longer-term management strategies, which might include therapy, medication, or both.
Right. And following panic disorder, the chapter addresses post-traumatic stress disorder, or PTSD. This is a condition we hear a lot about.
Absolutely. PTSD can develop after a person experiences or witnesses a terrifying event. The key feature is the persistent re-experiencing of that traumatic event.
How does that re-experiencing happen?
It can happen in various ways, like intrusive memories that just pop into their head, distressing nightmares, or flashbacks where they feel like the event is happening all over again.
Wow.
It's also important to note the book mentions that individuals facing significant health challenges, like cancer, can develop something called cancer-related PTS, which shares some similarities, but might be less severe.
Interesting. What kinds of events can lead to PTSD, according to the chapter?
The chapter lists a range of traumatic stressors: natural disasters, terrorist attacks, combat, serious accidents, rape, other criminal violence, and various forms of abuse, physical, sexual, emotional. The re-experiencing, especially those vivid flashbacks, is really a hallmark of the disorder.
What are some of the other signs and symptoms a nurse might observe in someone with PTSD?
Besides the re-experiencing, other common symptoms include persistent avoidance of stimuli associated with the trauma, like places or people. Also, negative alterations in mood and thinking, like feeling detached, emotionally numb, or having persistent negative beliefs about oneself or the world.
Okay.
And then there are marked alterations in arousal and reactivity. Things like being hypervigilant, always on guard, having an exaggerated startle response, irritability, or maybe reckless behavior. Sleep disturbances, difficulty concentrating, and feelings of guilt, especially survivor's guilt, are also frequently seen.
The interventions for PTSD seem to require a very sensitive and supportive approach. That makes sense.
They really do. Box 62.1 provides a good framework. It emphasizes providing non-judgmental support and, really importantly, validating the normalcy of their feelings and behaviors as understandable reactions to trauma.
So letting them know it's okay to feel that way.
Exactly. Assisting them in recognizing the connection between their current feelings and behaviors and the traumatic event is also important.
Yeah.
Encourage them to express their emotions, but always at their own pace.
Right.
Individual therapy is often crucial for addressing issues like loss of control and anger. Teaching adaptive coping skills and relaxation techniques is vital. Encourage participation in support groups, too. Connecting with others who understand can be powerful.
What about talking about the trauma itself?
Facilitating a gradual and controlled review of the trauma, when the client is ready and feels safe, can be therapeutic. Support them in establishing or re-establishing meaningful relationships. The chapter also mentions potential adjunctive therapies like hypnotherapy and desensitization techniques might be options for some.
That's a very helpful overview of PTSD care. Moving on, the chapter covers specific phobias. What distinguishes a phobia from just being normally scared of something?
Good question. A specific phobia is an irrational and persistent fear of a specific object or situation. It leads to significant distress and, crucially, avoidance behavior. The fear is way out of proportion to the actual danger posed.
Okay.
If avoidance is impossible, exposure to the phobic stimulus almost invariably provokes an immediate, intense anxiety response, which might even escalate to a full-blown panic attack.
And box 62 in the chapter provides a long list of different types of specific phobias, doesn't it?
It does, a whole bunch. It includes common ones like acrophobia, heights, agoraphobia, open space, we'll come back to that, claustrophobia, closed spaces, and social phobia. But also more specific ones like hematophobia, blood, cynophobia, dogs, you name it.
When we're caring for someone with a specific phobia, what are the key nursing interventions?
Well, the initial step is to help the client identify the basis of their anxiety related to the feared object or situation. Encourage them to verbalize their feelings about it. Just talking about it can be the beginning of desensitization.
Makes sense.
Teach them various relaxation techniques, deep breathing, progressive muscle relaxation, guided imagery to help manage their anxiety when they think about or encounter the feared thing.
And then?
A core intervention is gradual desensitization. This means they are exposed to the feared object or situation in a controlled, incremental way, starting small.
Right, little steps.
Exactly. It's crucial to stay with the client during any exposure and never, ever force contact with a phobic object or situation. That can be re-traumatizing and counterproductive.
That gradual approach sounds much more manageable than just confronting the fear head-on without preparation. Okay, next we move into obsessive-compulsive related disorders. This is more than just liking things to be tidy, isn't it?
Oh, absolutely, much more. Obsessions are recurrent and persistent thoughts, urges, or images that are experienced as intrusive and unwanted. They cause marked anxiety or distress for most people.
Okay, those are the obsessions.
And compulsions are repetitive behaviors like hand-washing, ordering, checking, or mental acts like praying, counting, repeating words silently that an individual feels driven to perform.
Why do they do them?
They do them in response to an obsession, or according to rules that feel like they must be applied rigidly. The goal is often to prevent some dreaded event or situation, or to reduce the anxiety caused by the obsession.
But it takes up a lot of time.
Exactly. These obsessions and compulsions are time-consuming, cause significant distress, and impair functioning in social, work, or other important areas. The anxiety stems from trying to resist them or feeling unable to control them. Obsessive thoughts can center around various themes: contamination, harm, symmetry, forbidden thoughts, orderliness.
And the chapter lists some related disorders beyond classic OCD.
Yes, it does. These include hoarding disorder, excoriation, which is skin-picking disorder, trichotillomania, hair-pulling disorder, body dysmorphic disorder, and also OCD that's induced by a substance or medication or due to another medical condition.
What are the important nursing interventions for these disorders? Box 62-3 covers this, right?
Right. Interventions focus on ensuring basic needs, like adequate nutrition, rest, and hygiene are met. Because sometimes the rituals interfere with self-care. Try to identify situations that seem to trigger the obsessions or compulsions.
Okay.
Encourage the client to verbalize their feelings. Approach them with empathy, recognizing the distress these behaviors cause, even though they feel compelled to do them. Avoid interrupting the compulsive behaviors unless they are directly causing harm. Safety first, always.
So you let them do the ritual,
But you gradually set limits on behaviors that interfere with their well-being to prevent harm. Implement a structured schedule with activities that can help distract them, like simple games or tasks. Establishing a written contract outlining a gradual decrease in the frequency or intensity of the compulsions can be helpful. And really importantly, recognize and positively reinforce any instances of non-ritualistic behavior. Give praise for the positive steps.
That makes sense, acknowledging their distress while gently guiding them towards healthier coping mechanisms. The chapter then transitions to somatic symptom and related disorders. This is where psychological distress manifests as physical symptoms, right?
Exactly, spot on. Somatic symptom disorders are characterized by one or more physical symptoms that are distressing or result in significant disruption of daily life. And crucially, there are excessive thoughts, feelings, or behaviors related to these somatic symptoms or associated health concerns.
So the focus is really on the physical stuff.
Yes, the individual's focus on their physical symptoms is persistent and excessive. It's important to note that the physical symptoms may or may not have a clear medical explanation. The underlying anxiety is often expressed or channeled through these physical complaints.
And sometimes there's a secondary gain.
Sometimes, yes. This might involve receiving attention or avoiding responsibilities, though this process is usually unconscious. They aren't typically faking it consciously.
Got it. And within this category, the chapter discusses conversion disorder. What's the key characteristic there?
Conversion disorder, also known as functional neurological symptom disorder, involves one or more symptoms of altered voluntary motor or sensory function. Things like weakness, paralysis, abnormal movement, blindness, numbness, speech problems.
But there's no medical cause.
Right. These symptoms are not consistent with recognized neurological or medical conditions and are often associated with some kind of psychological conflict or stress. The symptom isn't intentionally produced, and the development of the physical symptom is often thought to unconsciously reduce the individual's anxiety related to that underlying conflict.
So how do we approach nursing interventions for somatic symptom and related disorders? Seems tricky.
It requires a careful approach. The initial step is always a thorough assessment, including a comprehensive history and physical exam to rule out any actual organic medical conditions.
Rule out the physical first.
Absolutely. Then it's important to explore what needs might be being met by the physical symptoms and help the client identify alternative, healthier ways to meet those needs. Assist them in recognizing potential connections between their feelings, conflicts, and their physical symptoms.
How do you talk to them about the symptoms being real?
It's crucial to convey to the client that you understand their symptoms are real to them, even if a medical cause hasn't been found. Reassure them that serious physical illness has been ruled out. Explore the potential sources of their anxiety and encourage them to verbalize these feelings.
Okay.
Teach and encourage relaxation techniques, especially when anxiety levels rise. If pain is reported, use a pain scale and implement comfort measures. Monitor and report any new physical complaints. Encourage participation in diversional activities to shift their focus away from the body.
And providing feedback.
Yes, provide positive feedback for their engagement in therapy and any steps they take towards managing their symptoms. Help them identify and express emotions directly. Meds like anti-anxiety or antidepressants might be prescribed. A key nursing approach, though, is to allow a specific, limited amount of time for the client to discuss physical complaints, acknowledging their experience without reinforcing an excessive focus. Don't give undue attention just for the physical complaints.
That's a very delicate balance, validating their experience while not reinforcing the somatic focus. Okay, next we look at dissociative disorders. These involve disruptions in memory, identity, consciousness, or perception. These often have a link to trauma, don't they?
Yes, very often. Dissociative disorders are characterized by a disturbance in, or a discontinuity of, the normal integration of consciousness, memory, identity, emotion, perception, body representation, motor control, and behavior. These disorders frequently develop following significant trauma.
The chapter outlines a few specific types. Can you walk us through them?
Sure. There's dissociative identity disorder, or DD. This was formerly known as multiple personality disorder. It's characterized by the presence of two or more distinct personality states, sometimes described as an experience of possession.
Different personalities.
Yes, each state may have its own pattern of perceiving, relating to, and thinking about the environment and self. Then there's dissociative amnesia. This involves an inability to recall important autobiographical information, usually of a traumatic or stressful nature, that's way beyond ordinary forgetfulness.
Forgetting parts of their life.
Exactly. In some cases, this can include what's called a dissociative fugue, where the person suddenly travels away from home and can't recall their past or identity.
Wow.
Finally, there's depersonalization, derealization disorder. This involves persistent or recurrent experiences of depersonalization, feeling detached from one's own body or mental processes, like being an outside observer, and derealization, feelings of unreality about the surroundings, like the world is dreamlike or distorted.
What are the primary nursing interventions for individuals with these dissociative disorders?
Developing a sense of safety and trust is absolutely paramount in the therapeutic relationship. Encourage the client to verbally express painful experiences, anxieties, and concerns, but always at their own pace when they feel ready.
Okay.
Explore their current coping mechanisms and help them identify healthier, more adaptive strategies. Assist them in identifying the sources of their internal conflicts. Focus on their strengths and existing skills. If disorientation occurs, provide gentle and consistent reorientation.
And therapy.
Implement stress reduction techniques. Long-term psychotherapy, often involving individual, group, and family approaches, is typically necessary to help integrate the dissociated aspects of their experience and develop a more cohesive sense of self. It's often a long road.
That emphasizes the long-term therapeutic work involved. Okay, now we move into a major category. Mood disorders, starting with bipolar and related disorders. The defining characteristic here is the shift between manic and depressive episodes, right?
Exactly. Bipolar and related disorders are characterized by significant fluctuations in mood, energy, activity levels, thinking, and behavior. These typically involve alternating periods of elevated mood mania or the less severe hypomania and lowered mood, which is depression, often with periods of relatively normal mood in between.
And box 62-4 in the chapter helps compare mania and depression symptoms.
Yes, it's a really helpful comparison. On the mania side, you see things like inflated self-esteem or grandiosity, a significantly decreased need for sleep, being much more talkative than usual, racing thoughts or flight of ideas, distractibility, increased goal-directed activity like at work, school, or socially, or psychomotor agitation, and excessive involvement in activities with a high potential for painful consequences like spending sprees, sexual indiscretions, foolish business investments.
It paints a picture of someone with very high energy and often poor judgment. risky behavior.
Definitely. And then on the depression side, you see symptoms like significant sadness, feeling empty or hopeless, loss of interest or pleasure in almost all activities, major changes in appetite or weight, insomnia or sleeping way too much, fatigue or loss of energy nearly every day, feelings of worthlessness or excessive guilt, difficulty thinking or concentrating, and recurrent thoughts of death or suicide. The contrast between these two poles is really striking.
The interventions for mania, described in box 62 to 5, seem very focused on maintaining safety and managing that elevated energy and impulsivity. That makes sense.
They absolutely have to be. Safety is paramount. When addressing aggressive behavior in a manic client, you want to help them identify feelings of anger and frustration and encourage verbal expression in a safe way. Work to identify triggers for their aggression and help them develop alternative coping strategies.
And de-escalation.
For de-escalation, prioritize safety for everyone, respect personal space, use a calm and even tone of voice, and offer clear, simple options to help them regain control. Avoid power struggles.
What about manipulative behaviors? That comes up too.
Yes. When dealing with manipulative behaviors, it's essential to set clear, consistent, and realistic limits. Follow through with consequences in a non-punitive way. Help the client understand the impact of their behavior and assist them in setting their own internal limits.
And other general interventions for mania.
Remove hazardous objects from the environment. Monitor closely for physical exhaustion. They might not realize how tired they are. Promote frequent rest periods, maybe in a private room, to minimize stimulation. Encourage expression of feelings in calm, controlled interactions. Help them focus on one topic at a time.
What about grandiosity?
Gently redirect any grandiose or unrealistic thinking back to reality, but don't argue. Limit involvement in large group activities if they get overstimulated. Provide high-calorie, nutritious finger foods and fluids frequently because they might not sit down to eat. Supervise clothing choices for appropriateness. Reduce overall environmental stimuli. Set firm limits on inappropriate behaviors. Offer constructive outlets for energy, like walks or simple, non-competitive activities. Engage them in structured one-on-one activities. Use simple, direct explanations. And closely supervise medication administration. Adherence can be a big issue.
Okay, lot to manage there. And the chapter does then go on to discuss depressive disorders in more detail, right?
Yes. Section IX focuses specifically on depressive disorders. These are characterized by that presence of sad, empty, or irritable mood, along with somatic and cognitive changes that significantly affect the individual's ability to function.
And it can follow a loss.
Often, yes. Depression can occur after a loss of self-esteem, end of a relationship, death of a loved one, a trauma. Grief is normal, but if the grieving process becomes prolonged or stuck, it can lead to depression.
How are they treated?
Depressive disorders range from mild to severe. Treatment typically involves a combination of psychotherapy, antidepressant medications, and in some cases, electroconvulsive therapy, or ECT, which we'll get to. Box 62-4 also gives that overview of depression symptoms we looked at.
Right. Reviewing box 62 to 4, again, alongside the low mood and loss of interest, it also mentions those changes in appetite and sleep, fatigue, feelings of worthlessness, difficulty concentrating, even slowed physical movements or psychomotor retardation. It really highlights how pervasive depression can be.
Absolutely. It affects everything.
Yeah.
Now, box 62-6 outlines key nursing interventions for individuals experiencing depression. A primary concern is always the risk for harm.
Suicide risk.
Exactly. It's crucial to directly assess for suicidal ideation. Ask directly, have you had thoughts of hurting yourself? If suicidality is present, prioritize safety immediately. Remove harmful objects, ensure the client isn't left alone for extended periods, provide one-to-one supervision if there's an immediate high risk, and consider a no-suicide contract if appropriate for that person.
Okay. What about activities?
Gently encourage participation in basic self-care and unit therapies, but don't push them to make complex decisions when they're feeling overwhelmed. Offer achievable activities that provide a sense of success, focusing on strengths. Start with one-on-one interactions, then maybe small groups later. Simple tasks that don't require high concentration.
And basic needs like nutrition and hygiene.
Monitor food and fluid intake and weight closely. Offer small, frequent, high-calorie, high-protein snacks and fluids. Stay with them during mealtimes if needed for encouragement. Pay close attention to hygiene and self-care deficits can indicate worsening depression. Provide assistance with ADLs as needed.
Sleep is often disrupted too.
Monitor their sleep patterns. Create a relaxing bedtime environment. Reduce stimuli. Spend some quiet time with them before bed.
How do you address their altered thought processes, those negative thoughts?
Remind them of times they felt better or were successful, gently. Spend time with them just being present. conveying a sense of worth. Encourage them to discuss losses or changes. Allow them to express sadness and anger safely, giving them time to respond. Respond therapeutically if they express anger. And a really, really critical point. Monitor depressed clients closely, especially those just starting antidepressants, for any signs of increased energy.
Why increased energy? Isn't that good?
It can be. But sometimes the energy returns before the mood fully lifts, which might give them the capacity to act on suicidal thoughts they previously lacked the energy for.
So increased energy needs very close monitoring.
That's a really crucial point about monitoring for increased energy in the context of potential suicidality.
Okay.
Next, the chapter discusses electroconvulsive therapy, or ECT. While sometimes controversial in public perception, it's still a valid treatment in certain circumstances, isn't it? Yes, absolutely. ECT is a highly effective treatment for severe depression, and some other conditions too, although it's not considered a cure. It involves briefly passing a small electrical current through the brain to intentionally trigger a brief controlled seizure.
And the patient is asleep.
Yes. Before the procedure, the client gets a muscle relaxant, so you usually only see slight twitching of hands or feet, and a short-acting anesthetic so they are asleep and don't experience it. There are certain conditions that increase risk, like a recent heart attack, stroke, or an intracranial mass lesion.
Box 62-7 in the chapter outlines the specific situations where ECT might be considered. What are those key uses?
Right. ECT may be indicated when antidepressants haven't worked or when a rapid response is needed, like with severe suicidality or homicidality, also for extreme agitation or stupor, or when the risks of other treatments outweigh ECT's risks.
Okay.
Also for individuals who have a history of responding well to ECT but not meds, or vice versa. And sometimes it's based on client preference after they're fully informed.
What are the essential nursing responsibilities before, during, and after an ECT procedure? It seems like a lot of monitoring.
It is. Pre-procedure care includes explaining everything thoroughly to the client and family, encouraging discussion about fears or myths, teaching what to expect, getting informed consent, which might involve next of kin or even a court order in some cases.
And practical prep.
Making sure the client is NPO after midnight, or at least 4 hours before, getting baseline vitals, having the client void, removing hairpins, contacts, dentures, and giving any prescribed pre-meds.
During the procedure.
Nurses assist with IV insertion, applying EEG and ECG electrodes, monitoring BP, pulse, O2 sat. Usually a BP cuff goes on one ankle and is inflated to block the muscle relaxant there, so you can see the seizure activity in that foot. Anesthetic and muscle relaxant are given, oxygen via mask, an airway is placed to protect the tongue, then the electrical stimulus is administered, causing the brief seizure.
And post-procedure.
Transport to recovery, continue monitoring vitals and O2 sat, have suction and emergency equipment ready. When the client wakes up, talk to them calmly, reorient them. Confusion is common right afterwards. Frequent, brief, simple orientation helps. They can return to the unit when O2 sat is good, vitals stable, mental status okay, and crucially, check for the gag reflex before offering any fluids, food, or meds.
What about side effects?
Potential side effects include that confusion and disorientation, short-term memory loss around the procedure time, headache, maybe some hypotension, muscle soreness, nausea, or tachycardia. Memory issues are usually temporary, but some people might experience loss for up to 6 months, though that's less common now with modern techniques.
That's a very comprehensive overview of ECT from a nursing perspective. Okay, the chapter then transitions to schizophrenia. This is a complex group of disorders, often characterized by psychotic symptoms like hallucinations and delusions. What's the fundamental understanding we need to take away about schizophrenia?
Schizophrenia is a chronic and severe mental disorder affecting how a person thinks, feels, and behaves. It's really a spectrum of disorders characterized by a mix of symptoms. We often talk about positive symptoms.
Like hallucinations and delusions.
Exactly. And negative symptoms like flat affect, reduced emotional expression or avolition, a lack of motivation, social withdrawal, and also cognitive deficits, problems with attention, memory, executive function. These disturbances significantly impact functioning and relationships. Medication is really a cornerstone of treatment to help control symptoms.
And figure 62-1 in the chapter kind of breaks down these different areas.
Yes, it provides a helpful framework outlining the physical, motor, emotional, compulsive, affective, and thought process disturbances often seen.
Looking at that figure, it really underscores the multifaceted nature of schizophrenia. It affects so many different areas of a person's life.
Absolutely. Physically, you might see poor hygiene, self-care neglect, maybe body image distortions. Motor behaviors can range from catatonia, being immobile or holding bizarre postures, to agitation and repetitive movements. Emotionally, there might be mistrust, seeing the world as threatening, blunted, or inappropriate affect, ambivalence, anxiety, anger, depression.
And the thought processes.
That's where you see things like the delusions and disturbed thinking patterns. Box 62-8 elaborates on those abnormal thought processes like circumstantiality, flight of ideas, loose associations, neologisms, making up words, thought blocking, word salad. Box 62-9 describes different types of delusions: grandeur, persecution, somatic. Box 62-10 covers perceptual disturbances like illusions and hallucinations, auditory being the most common. And Box 62-11 covers language issues like clang associations, echolalia, mutism, pressured speech.
That's a lot to process. Let's focus on some of those key positive symptoms, like hallucinations and delusions. What are the priority nursing actions when someone is experiencing these? Safety seems huge.
Safety is the absolute top priority, especially with hallucinations. You must assess for command hallucinations, voices telling the client to harm themselves or others. That's critical.
Okay, so assess for command hallucinations first. Then what?
Immediate interventions include establishing one-on-one contact to closely monitor. Reduce environmental stimuli, move to a quieter area. Avoid validating the hallucination. Don't act like it's real, but don't dismiss their experience either.
How do you phrase that?
You might say something like, "I understand you are hearing voices, but I don't hear them." Focus the conversation on real events, real topics. Avoid touching without warning. Encourage them to express the feelings the hallucination evokes: fear, anxiety. Try to engage their attention in a simple, concrete activity. Monitor for increasing anxiety or agitation, and administer prescribed antipsychotics.
What about delusions? How do you handle those?
For delusions, Box 62-9 suggests interacting based in reality. Encourage expression of the feelings the delusion generates, but don't argue or try to disprove the delusion itself. It usually doesn't work and can damage trust. Initially, one-on-one activities are better. If paranoia involves food, maybe offer packaged items and acknowledge any real accomplishments or positive behaviors.
And Box 6212 provides an even broader range of nursing interventions for schizophrenia, right? Covering a lot of ground.
Yes, it's very comprehensive. It includes assessing basic physical needs, setting limits on disruptive behavior, maintaining safety, starting with one-on-one then small groups, spending time even if unresponsive, monitoring thought processes, maintaining boundaries, like avoiding unnecessary touch, using a neutral approach, avoiding false promises.
Routines seem important too.
Very. Establishing routines, assisting with grooming, being present silently if needed, brief, frequent contact, telling them when you leave, clarifying if you don't understand, not going along with psychosis, offering simple, concrete activities, reorienting as needed, helping distinguish real from unreal, staying if frightened, using simple, direct speech, reassuring safety, removing from groups if disruptive, setting realistic goals, initially limiting choices then gradually increasing them, considering those packaged foods, using music for sleep, minimizing stimuli, monitoring suicide risk, and helping find alternative expression like art or writing.
That gives us a very thorough understanding of the nursing care involved in schizophrenia. Okay, the chapter then transitions to personality disorders. These are characterized by those long-standing, inflexible patterns of behavior and inner experience, right, that cause problems.
Exactly. Personality disorders involve enduring patterns of perceiving, relating to, and thinking about the environment and oneself that are inflexible, pervasive across many situations, and lead to significant distress or impairment in functioning. A key thing is that individuals often lack insight into their own problematic behaviors and how they affect others.
And stress makes it worse.
Yes, stress often exacerbates symptoms. In severe cases, they might even experience brief psychotic episodes.
The chapter outlines several key characteristics common across these disorders. What are some of those core features?
Common characteristics include difficulties with impulse control leading to aggression, self-injury, substance abuse, risky behavior, intense and unstable emotions, abandonment fears, depression, rage, emptiness, impaired judgment, poor problem-solving, not seeing consequences, impaired reality testing, distortions, projection, impaired relationships, often unstable, inflexible, difficulty with intimacy, distorted self-perception, self-hate or idealization, impaired thought processes, concentration issues, and often impaired stimulus barrier, they get overwhelmed easily.
And the chapter groups these into 3 clusters, A, B, and C. Can you briefly describe the gist of each cluster?
Sure. Cluster A is the oddie-centric cluster. Includes paranoid, suspicious, mistrustful, schizoid, detached, restricted emotions, and schizotypal, odd beliefs thinking, discomfort with close relationships.
Okay, oddie-centric. Cluster B.
Cluster B is the dramatic, emotional, erratic cluster. This includes antisocial, disregard for others' rights, deceitful, impulsive, borderline instability in relationships, self-image, mood, impulsive, histrionic, excessive emotionality, attention-seeking, and narcissistic. Grandiosity, need for admiration, lack of empathy.
Dramatis emotional.
Yeah.
And cluster C.
Cluster C is the anxious, fearful cluster. This includes avoidant, social inhibition, feelings of inadequacy, hypersensitive to criticism, dependent, needing to be taken care of, submissive, fears separation, and obsessive-compulsive personality disorder, which is different from OCD, characterized by preoccupation with orderliness, perfectionism, and control. Box 6213 specifically highlights interventions for paranoid personality disorder, focusing on building trust slowly, avoiding suspiciousness, promoting self-esteem, and being consistent. Don't whisper around them.
Right, that makes sense. Cluster B contains some of the ones people hear about more often, like borderline and antisocial.
Yes, they often present significant challenges in care settings due to the impulsivity, emotional dysregulation, and interpersonal difficulties.
And cluster C, the anxious, fearful ones, involves a lot of internal distress too.
Definitely. Avoidant types suffer greatly from fear of rejection. Dependent types struggle with functioning independently. And OCPD types can be rigid and struggle with relationships due to their need for control.
The chapter also provides some general nursing interventions that apply across many personality disorders. What are some key strategies there?
General interventions include, again, prioritizing safety, especially regarding self-destructive behaviors. Provide opportunities for choices and independence within safe limits. Encourage discussing feelings rather than acting them out. Maintain consistency in responses, especially around limit setting. Clearly discuss expectations, responsibilities, and consequences.
Setting boundaries is key.
Crucial. Inform them that harm to self, others, or property is unacceptable. Be aware of and address splitting, seeing people as all good or all bad. Assist with anger management. Written safety or behavioral contracts can sometimes help. Encourage journaling. Promote group activities, praising positive, non-manipulative interactions. Set and maintain clear limits to decrease manipulation. Remove from group situations if they're being disruptive, just for attention. And provide realistic praise for positive social behaviors.
The chapter then briefly touches on neurodevelopmental disorders like autism and ADHD, referring us back to chapter 35 for the details. It then moves into neurocognitive disorders, primarily focusing on dementia and Alzheimer's disease. So relevant for nursing.
Hugely relevant. Dementia is an umbrella term for syndromes involving a decline in cognitive function. Memory, language, problem-solving severe enough to interfere with daily life. It's beyond normal aging. Alzheimer's disease is the most common cause, a progressive brain disorder.
And Box 6214 lists key terms like agnosia, amnesia, aphasia, apraxia.
Yes, agnosia is failure to recognize objects. Amnesia is memory loss. Aphasia is language disturbance. Apraxia is inability to perform motor activities despite intact motor function. Alzheimer's involves steady cognitive and functional decline, often progressing through stages from mild forgetfulness to severe impairment needing total care.
The nursing interventions for dementia and Alzheimer's place a strong emphasis on safety and maximizing the individual's remaining abilities, right?
Yes, absolutely. Key interventions include identifying and reinforcing retained skills, providing consistency in caregivers and routines. It's huge. Orienting them frequently using clocks, calendars, familiar objects, acknowledging their feelings without arguing about their reality. Helping the client and family manage memory and behavior changes.
Supporting the family is important too.
Very important. Encourage families to express feelings, provide support and resources. Monitor ADLs, offer assistance and reminders, but support independence as much as possible. Establish predictable routines. Encourage gentle exercise like walking. Avoid activities that overly tax memory. Allow ample time for tasks. Use constant reassurance, simple step-by-step instructions. Provide engaging but simple activities, music, coloring.
What about wandering? That's a common concern.
Prioritize a safe environment, close supervision, secure doors, ID bracelets, maybe alarms. Be aware of sundowning, increased confusion and agitation in the evening. Safety is always number one.
And communication.
Adapt to their level. Use a firm, low-pitched voice. Face them. Make eye contact. Call them by name. Identify yourself. Calm, reassuring tone. Pantomime if needed. Speak slowly, clearly, short words, simple sentences. One question or direction at a time. Repeat as needed. Don't necessarily rephrase unless they're stuck.
What about managing the environment for safety and confusion?
Address impaired judgment by removing hazards like throw rods, toxins. Reduce hot water temp. For altered thought processes, use their name, frequent orientation, familiar objects, routines, encourage reminiscing, simple tasks, allow time positive reinforcement. For altered sleep, allow safe daytime wandering until tired, use nightlights, avoid hypnotics if possible as they can worsen confusion.
And agitation.
Assess the precipitant, what triggered it. Reassure calmly. Remove hazards. Approach slowly, calmly from the front. Speak, gesture, move slowly. Less stressful environment. Decrease stimuli. Gentle touch might help, if acceptable. Don't argue or force things. Try to redirect.
The chapter then wraps up with the answer to that critical thinking question about intervening with hallucinations, which we covered, and then a really helpful set of practice questions with detailed rationales.
Exactly. Those questions are great for solidifying understanding. They test your application of these concepts, managing confusion, hallucinations, depression, ECT, mania, command hallucinations, psychosis, catatonia, anxiety, phobias, conversion disorder, delusions. The rationales explain why an answer is right or wrong, which is crucial for learning.
So we have truly covered the entirety of Chapter 62 from Saunders. We've explored definitions, assessment interventions, safety for anxiety, trauma, OCD, somatic, dissociative disorders,
Mood disorders like bipolar and depression, schizophrenia, personality disorders, and neurocognitive disorders like dementia and Alzheimer's, plus ECT and those practice questions.
It's been a comprehensive deep dive into the essential nursing knowledge from this chapter, really laying a solid foundation for understanding and caring for individuals experiencing these mental health challenges.
Yes, hopefully providing you with a really useful overview, especially for your NCLEX-PN prep in your future practice.
And with that, here's a final thought for you to consider. Think about the profound, undeniable interconnectedness of mental and physical health. As nurses, our ability to understand, empathize, and respond effectively and knowledgeably to mental health concerns is absolutely integral to providing that truly holistic and compassionate care we strive for. Maybe this deep dive has sparked your interest in digging even deeper into a specific disorder or treatment approach that caught your attention today. Thanks for joining us.